Also joining us for a different conversation is Dr. Zahra Mohamed Ahmed, radiation oncologist at HCG Center. That is Cancer Center. HCG Cancer Center. I hope I've said it correctly. Is it Ahmed? Right?
Yes, Ahmed.
Okay. Did I say it correctly? But welcome, Dr. Zahra. The last time you were here, we had a very lengthy conversation on matters to do with cancer.
Yeah.
And you're back here today to talk about the evolution in cancer treatment and diagnosis. We also had a different conversation here a couple of days ago with what's the name of Dr. Miss Keller. He's a gyna, and he was talking about just how easy it is nowadays to treat cervical cancer if it is caught early in time, when it's still in its inception stage. And he spoke about several the different methods that we can use to tackle cervical cancer, and that put a smile on my face, because I was thinking, so some of these things do not have to be a death sentence necessarily. Yeah. So welcome to Radio Generation once again.
Thank you so much. Good morning. Yeah.
Did you have breakfast?
I had coffee.
So I was going to ask them to bring a burger, but kama umeshakula umeshiba, saa tuingie sasa tuanze kazi.
Yes.
Let's talk about the evolution in cancer treatment and diagnosis. What exactly do we mean by that?
So I think it's just how far we've come, and the truth is we've come a long way. Previously, it was when we were talking about cancer care. Cancer care was a story of despair, but currently it's a story of progress, innovation, and hope. We've really moved from where it was one type of treatment fits all, but now we have specialized, personalized treatment where we can treat each individual according to their own personalized, like genomics. Yeah.
Genomics?
Yes.
That we're talking about genes here, right?
Yes.
Okay.
So like, before we go there, like cancer treatment involves medical and radiation.
Right.
So for the medical and surgical also, so for the medical perspective, we have chemotherapy, targeted therapy, and immunotherapy. And for the radiation therapy is where I think last time we spoke about how radiation penetrates into the tumor cells and kills cancer cells by killing the DNA of the abnormal cell.
So, wait, that is which part of which
radiation?
That's radiation.
Therapy, yes.
Radiation targets the DNA of the cancer cells.
Yes. So while talking about evolution, we had our first radiation machine in 1960s, 1970s. I think it was brought by a certain group, Canadian and KNH, Karolinski. It was a partnership where we had the first cobalt then, but we didn't have a radiation oncologist at that time.
Do you know how I figured radiation is done?
Yes.
So I thought radiation is, of course, it's a laser.
Yes.
It's a light that goes and literally kills the cell. I just didn't know it attacks the DNA.
So how radiotherapy works, so it's a beam of ray. With the linear accelerators, we use accelerated electrons that are able to penetrate deeper into the target tissue.
Okay.
So currently we are doing more personalized treatment in radiation. We are doing more, so there are different modalities of delivering radiotherapy. Like previously we used to treat more of 2D. 2D means the rays are just coming and you're using bony marks to treat that area.
Right.
But at the meantime, we have technologies in which I think HCG, we are the only facility in the whole of sub-Saharan Africa where we are doing stereotactic radiotherapy. I think I mentioned this last time.
Yes, you did.
Yes. So we are doing more precise treatment in which the side effects will be extremely low and we are able to target the tissue.
So for the sake of the listener and probably viewer also visualizing this concept, so let's say we are trying to attack cancer cells that are inside my arm somewhere here, in my hand, right? And then we focus the laser here. Will it also end up killing the cells on the surface as they reach the ones underneath?
So just a small description of what radiotherapy entails. So you have the tumor. And when we are doing treatment, you have to undergo imaging. And part of evolution is diagnostic has really evolved over time. Currently, we have very like MRIs and PET scans where we are able to identify diseases at a very early stage. Even the ones that have spread, you can able to detect them very early.
Okay.
So once you have that tumor, with radiation, the doctor, radiation oncologist, after you have undergone imaging, will draw that tumor, and that will be the GTV, meaning the gross tumor volume. And then we will keep, like for the more modernized specialized treatment, the margin around it will be very minimum, like 0.3.
Okay.
And this margin is supposed to take care of subclinical disease. Understood? Because you have the gross disease, what you can see, and then there's the subclinical disease. So this will be the clinical tumor volume. So I will also add a small margin known as the planning tumor volume to take care of any immobilities during treatment. So once I've drawn this, the machine will be able to recognize this as disease and focus these rays of radiation only to this area of treatment. So by doing so, the nearby organs do not get any or just minimum radiation with minimum side effects.
Okay.
That's what we mean by more specialized target precision treatment.
Okay.
Yeah.
All right. Well,
You know, the thing about understanding this particular specialty of yours
Yes.
is in actually knowing what and when and how. What it is that it actually does, when it is needed,
Yeah.
and how it is actually put to work so that the person who needs it can actually benefit from it.
Definitely. And I think with that being said, currently we only treat under multidisciplinary management, meaning that I, as a radiation oncologist, when we have a case, we have to sit with the surgeons. Like for a gyne case, if we have a cervix case, we will have a gyne oncologist. What I was saying about specialized treatment.
Yeah.
So we have a gyne onc, you have the radiation oncologist, you have the pathologist and the radiologist. One, you have to diagnose.
Yes.
So with diagnosis, you have to start with pathology, right? Pathology meaning that you have to take a sample and it has to be tested for it to be confirmed that it is cancer or not. After you have confirmed you have cancer, then you go to the staging. What is this patient's stage? So you go through radiology, and as I have said, we have when it's indicated, you can do a PET scan, of which you can really get, it's a very accurate staging modality. So you get the staging done. Once the staging is done, then the doctors sit together and discuss what's the right treatment.
Okay.
Like for cervical cancer again, the patient does not need to undergo surgery if the patient is stage 2. Surgery is not a treatment of choice because this patient can undergo concomitant, meaning a combination of chemoradiotherapy with a curative intent. Understood? So once you sit with that gyne onc and understand that you discuss together, like, I don't think this is a surgical candidate because of this, this, and this. And okay, so we are going to give radiotherapy and I will give radiotherapy. This is the treatment that I will offer. So what I'm saying is multidisciplinary management is extremely important. It is not just my patient, it is our patient. Once we discuss together, we tend to offer more specialized care and
But-
the right treatment.
But this multidisciplinary care is the ideal.
Yes, we are really there, honestly.
You are there, established. But is this what we see in other health facilities where such services are offered?
Yes, I think any facility that has cancer specialized treatment, KNH, Mombasa, speak about it. They do have multidisciplinary discussions. Like right now, you in the morning you have tumor boards, and every day there's a tumor board for a certain speciality.
What's a tumor board?
Tumor board is where all the doctors sit together. That's the multidisciplinary team. So all the doctors sit together and discuss this topic, and we offer the best treatment approach possible for this patient.
so this is something that is discussed at the hospital level.
Yes, we also have virtual presentations.
Okay.
Yeah.
So there's a question I have. My mother had this ampullary cancer, and
Yes.
it was treated back in 2021,
Yes.
I think. And she did surgery, wakatoa kila kitu.
Okay.
Then she still went for chemo.
Okay.
Why was the chemo necessary if the tumor had been removed?
So you see, let me explain something simple. There is a concept of pathological complete response. Your mother got chemo as part of adjuvant after surgery. Okay. So how do we treat cancer? We treat cancer based on research and data. Okay, we just don't say that this is the best treatment approach. And coming to the available data and the available recommendations, I think us as a continent, not even Kenya, we need to have our own data.
All right.
That being said, like, we depend on clinical trials, of which almost all of them, I was presenting on metastatic breast cancer, best of ASCO Africa. And while making the presentation, I found out that the clinical trials that were that were presented in the 2025 ASCO, all of them, or just 2, had 3 centers in Africa involved in those trials. And all of these centers were from South Africa. So you sit and ask yourself, like, does this data reflect our own genomics? Because we have different genomic profiles.
True.
We learn that this is the risk factor for development of this type of cancer. But what we see in the clinic is totally different. We have a huge, right now, we have a huge flow of breast cancers and colorectal cancers in very young individuals, 30s, and they have extremely aggressive tumors. But what is driving these tumors? You understand? In Western countries, the data that we depend on, their genomics is different. So I think coming to us as a continent, we need to have research of our own people. We need to find our own genomics, our own risk factors, so that we can be able to tailor treatment according to our people's factors. Yeah.
And do we do this, or are there attempts to do this?
I think there are attempts. We've started. There are centers running huge clinical trials. So we are starting. The clinical trials are starting, and I think it's something that we need to preach so that we can get there.
So essentially, research into this particular area is ongoing.
Yes, and we need to do more.
Is it okay? I was going to ask, is it research that is set to grow? Because if it's there, we understand it.
Yeah.
And given the diversity of cancers that we have, one research cannot be the begin and end all of all research on cancer.
Yeah.
Yes.
Yeah.
So now, the institutions you speak of, are they our universities?
We have, yes, we have clinical trials ongoing in Kenyatta. I know they share with us. And I think more trials are upcoming, and they should upcome.
None in Aga Khan?
There are several. Yes. But, okay, now, they should not just be in these big centers. Like, we should have several clinical trials throughout the country.
Ideally, that should be the case. But I am more concerned about, and why I'm asking specifically, because I know the University of Nairobi, because of the partnership there with Kenyatta National Hospital, you're likely to have it. Moi referral, you're likely to have it. Maybe Jaramogi Oginga Odinga may have it. These are centers that are already accustomed and tuned to medical research or biomedical research. They understand research. Now, this would be new. Now, if one finds research already present in these institutions, then we could say we are building a prevalence of these research processes, and they could grow, because these are people who have been known to do these things. And then I would ask, do we see it being done in Kemri? Because
yes, we do have. I think we've started. And we have a long way to go, but it's an initiative, and we have so many people who are willing. And let this research being done, at least let it start with us understanding our own biology, why we are having these prevalences of these types of cancers before being involved in those phase 3 trials. Like, a drug may not work for our patient population, but it works best for another patient population. What makes this what brings about this difference? So with genomics, we have a long way to go, but that's the whole point of precision medicine. Like, you treat this patient according to their own genomic profiling.
There's something I found, I had you rather talking to my producer about, like, there's a new machine.
Oh, yeah. So that in terms of radiotherapy, I told you, like, with HCG, we are offering very high precision modernized treatment. And I think it's in the whole of sub-Saharan Africa. we are doing stereotactic radiotherapy, of which the beauty of that is it's a precision targeted treatment in which the side effect profile is extremely low. You can escalate the dose. The normal radiation dose per day is 1.8 to 2 gray per fraction. The treatment time is a bit longer for you to achieve the total dose. But with stereotactic radiation, the dose per day can be 6, 7.5, 10 gray per fraction with shorter treatment period. So when you escalate the dose, you are getting the effectiveness of treatment is better, the side effect profile is lower, and the patient can complete treatment faster. And another thing that is very important in SBRT is, when someone is told you're a stage 4 cancer patient,
yes,
most of the times it comes with the impact that it's a death sentence. It's not. We have moved away from stage 4, meaning that you can be a stage 4 patient, a breast patient with one lesion in the breast. What does stage 4 mean? Stage 4 means the cancer has left where it started to another organ. Like if it is
so it
breast,
has left the breast to the
bone or to the lung or to the liver. That is what stage 4 means. Stage 1, 2, 3 means a localized cancer within the area where it started or within the regional draining nodal site. So with stage 4, it's cancer that has spread elsewhere. That is what it means. You see, many patients come to the clinic and the first thing they ask you when they've been diagnosed with cancer is, what's my stage? And they already, from that, they will lose hope. You understand? Like, you are a stage 4 patient because you have one bone lesion. And there is the concept of oligometastatic disease.
Okay.
So sorry.
Oligometastatic.
So metastasis means cancer has spread.
Explain oligo.
No worries. Okay.
Yeah. Oligo.
So stage 4 means cancer has spread from where it started elsewhere, right? So oligometastatic means the spread of cancer to a different organ is limited. There is low burden disease. Previously, we used to define it as either 3 to 5 lesions. Understood? So you might have bone disease, but there are just 3 bones involved. So there is data currently that when we treat these areas, we have a survival benefit, even though this patient is stage 4 patient.
Okay.
And it's not only the bones, and also brain, liver.
Even the brain.
Even the brain. Like you may have a breast cancer patient with disease that has spread to the brain.
Yeah.
According to the location, surgery is possible if it's one lesion, or you can even give radiotherapy. Either or in combination, depending on the location, depending on the size. So the disease might have spread from where it started, but it's not a death sentence. Treating this metastatic lesion when the burden is low, that is the whole concept of oligo, can give you a survival benefit.
Dr. Have you treated anyone with a stage 4 cancer and
Yes.
they have survived or probably even cured completely of cancer?
Let me tell you, breast patients do very well, especially a patient who has like limited bone disease, 1 to 3 lesions. You can do stereotactic radiotherapy. I think I have an ongoing patient with
Right.
a lung lesion. So we are treating that single lung lesion because the patient only has a single lung lesion. So we are treating that lung lesion with stereotactic radiotherapy. The patient is just getting 5 sessions, and then we discussed what more the patient will be able to be
When you're
getting.
saying only 5 sessions,
Yes.
meaning you could have more.
Meaning that the normal radiotherapy course goes for, depending on the primary, like for head and neck, it goes for 33 to 35 sessions.
Over
It's
what period of
around
time?
7 weeks, Monday to Friday daily treatment. Yes.
What?
For breast, it's 15 sessions.
And how long does one treatment session?
One treatment takes around 10 minutes with the more modernized machines.
Oh.
Yes, it takes about 10 minutes. But I think for our facility, you'll be given a time, like your time is from 2 to 3. And then 5 patients are booked within that time, and then you'll be treated. But the treatment on the machine is approximately, we
10
give
minutes.
it around 10 minutes. Yes.
So what we are saying is every day, for how many days? For 7 days? 7 days a week.
5
days a week.
days a week.
So Monday to Friday.
Yes.
I come for 10 minutes.
Yes.
For 7 weeks.
Yes. Treatment for that time for a period of 7 weeks. That is head and neck. Different areas have different periods of treatment.
Yeah.
So like let's talk about prostate. Prostate conventional radiotherapy takes 38 sessions. 38 sessions will be around the same time,
So
right?
10 minutes each.
Yes, around
38
7
times.
weeks. But with stereotactic radiotherapy, for the patients who are eligible of getting SBRT for the prostate, we treat them for 5 days. Because the dose per fraction is high. You understand? So you can achieve that, the biological effective dose, within 5 days only.
Okay.
What is... No, please.
What are the side effects of this? Because I remember you said it's you'll get treated for a shorter period of time, you'll get a higher dose, and the side effects are
extremely minimal.
Yeah.
One of the why patients get we have to understand why patients get side effects from radiotherapy. The whole point is, when you're treating an area, like for example when you're treating the prostate, there are nearby organs at risk.
Yes.
The bladder is in front, the rectum is behind, you have the femoral heads on the sides. Anything that surrounds where you are treating is an organ at risk, meaning that it may get a portion of the radiation you're delivering.
All right.
Now, with a more conformal treatment, you are only focusing the radiation to the area of treatment. Let me give you, like I just said, when you have contoured your GTV, the gross tumor volume, you have to add a margin for subclinical disease, right? Because of the conformality of stereotactic radiotherapy, the margin is just 0.3. But the margin for 3D used to be about 1 centimeter.
Yeah.
Yes, so you understand, when it's 1 centimeter, the dose to these other nearby organs will
Yeah.
at least be receiving a higher dose. So the whole concept of giving high precision radiation is that you are sparing these surrounding organs. Like if you're treating the breast, the lungs, the heart, the contralateral breast, all these areas are organs at risk. So you have to deliver your radiation in such a conformality that you are sure the dose prescribed goes exactly to where you have contoured or delineated, and the nearby organs at risk get minimum doses so that this patient does not have the side effects. Yes.
All right.
From everything you're saying, we are actually beginning to win this war.
We are. Cancer is not a death sentence. People have to understand it's not a death sentence. And I think previously, when you've been diagnosed with cancer, you lose hope and you first think about going outside for treatment and spending long days, weeks, months getting treatment. It came with financial toxicity, emotionally draining, because with cancer, don't only think about the patient, they're also the caregivers. It's also draining to the caregivers. So, but now, as a country, I think we have really moved forward. There is a long way to go, but we should also look at where we came from.
Let's look at the indicators of the success we're talking about. Once upon a time, it was assumed that if you wanted advanced treatment on something like cancer, you need to go to South Africa. Do we have a situation where now we find individuals on this continent from other countries around us coming to Kenya for treatment?
Oh, yes. Yeah, I have several patients from Congo, from Nigeria, several, by the way, and from South Sudan, even from far and wide. There was a patient who came for treatment from the States because it was more expensive there. So we have seen several patients coming from abroad, from UAE, several.
How can the Ministry of Health help with this so that we... Yes, I'm going somewhere with this. There's health tourism.
Yes, medical tourism.
Yes. What did I just call it?
Health. But you are, you're in the...
I wasn't too far away.
Yeah, you're in the neighborhood.
I was in the neighborhood.
Yeah.
Okay, so, because I do know of other disciplines where we have very many people, in fact, even from that very same country that I mentioned earlier on, coming to Kenya for treatment of the same. But then, how do we get people to understand the one thing that we talk about but we don't practice, the preventative aspects?
Yeah, I think as part of, I as a doctor and as part of the community, all of us, we need to first be aware. We should be aware of what is cancer, what are the alarming symptoms. If you've had a family history, what's your risk of getting this cancer? And after creating this awareness, we should come together and create. Screening programs are already there, but just empowering these screening programs, decentralizing them to rural areas, because where we have programs, but where do we have them most? Nairobi. We should decentralize these screening programs so that we can at least be able to diagnose at an, we have precancerous stage.
Yes.
Yes, you don't have to be diagnosed at a cancerous stage when it's already an invasive tumor. We can really detect these tumors at a very early stage, of which cure is 100%.
When it's benign.
When it's so when I say pre-invasive, I mean
Or it's already malignant, but it's just not.
it could be, yes. Yes.
Okay.
So a benign lesion is a lesion that is not capable of invading and metastasizing.
All right.
That's a benign lesion. A malignant lesion is one that is capable of going through the basement membrane and being able to spread. Now, even the malignant lesion, you can still get it when it's in situ, when it has not invaded, it has not become invasive. So at that time, treatment is less financially constrained, you need less money to get the treatment, and cure is 100%.
Now, in terms of, there are some cancers that are, people, when I go to hospital, for example, my local daktari pale clinic kwa mtaani might not recognize this as cancer and end up probably treating me for something absolutely different. For example, women who have got cervical cancer, is it possible to confuse that cancer for, let's say, a yeast infection?
Yes.
Or any, confuse it for chlamydia or syphilis or whatever?
Yeah. Yes, I think it's very possible, and that is why we need to empower our healthcare communities, because they are the people you will first meet. Let me give you examples, like gastric cancers. This patient will have a long-standing history of ulcers, gastric ulcers. This patient has been treated, most of the time has been treated for gastric ulcers for years. And once the patient now, the loss weight is very significant, you are like, no, this is not normal. Mom cannot eat. Mom has, the weight loss is like more than 5-10 kgs. So you go for more specialized care, and only then do you maybe recognize it, and it's maybe late. It's not only gastric. Let's talk about rectal. Patients are treated for piles. Hemorrhoids.
Okay.
Yes, because one of the symptoms is parectal bleeding. So maybe this patient has been treated several times for hemorrhoids without improvement, and when the patients come in, it's already too late. Cervical cancers, most of the symptoms is, by the way, the most early symptom is for some patients postcoital pain.
Pain after sex?
Yes.
Okay.
After, during, you feel some type of pain, but maybe the lack of awareness and all, and then the lesion grows. Patients then start experiencing pervaginal bleeding or pervaginal discharge. So you see, when that discharge starts and you go to your nearby healthcare providers, maybe without examination, it could be treated as an infection, because you have this discharge and you're like, I've noticed this discharge. Initially, it's not foul smelling, and then as the disease becomes progresses, it becomes foul smelling. So we've seen several cases of which initially these patients have been misdiagnosed with infections and all that. I think what we need to do is empower our healthcare providers, and I've said it before, have TOT trainings, so that we can be able to identify, we can have a high index of suspicion, identify these cancers earlier, and be able to give curative intent treatment at less cost.
Yeah. Do we have countries that are not necessarily even in Africa, for instance, that have a really, like, their
screening programs are,
and their detection is top-notch, yani?
Yes, we do. There's, I know several countries where once you reach, like for breast, after the age of 40, it's good to have a mammogram. So, like, once you reach 40, your hospital, the one you are assigned to, gives you a call to remind you that this month we are scheduling your mammogram. Kindly arrange yourself. You see, because by the way, doctors have a very poor health-seeking behavior. Yes,
as medical practitioners
yes,
yourselves.
as medical practitioners ourselves. And generally,
mganga hajigangi.
I don't know why is that.
Lakini hao wanajiganga.
I don't know why is that.
No, we are going to be better.
No, I really need to understand why is it?
Oh, you're actually waiting for an answer.
I am waiting for an
No,
answer.
we are becoming better. I think we are participating in the screening activities and all. But generally, we, even as a country, I think we don't have those high numbers of people going for screening. You understand?
Yeah.
But if maybe the government can come in and the hospital you're assigned to, you can be reminded about these screening times, which will force patients to go to hospital.
There's a small problem here when it comes to healthcare seeking behavior. So long as we attach it to a cost,
Oh, yeah.
there will always be the balancing between
True.
whether people eat at home,
Yeah.
Or
children go to school, and if I'm in pain, I will gauge, is this pain excruciating? If it's just ordinary pain,
If I can take
I
paracetamol
will
and I'm okay.
self-medicate.
Yeah.
True.
Okay.
There are months of which we have free screening programs, and I think these are the times that people really come out in high numbers, and to your surprise, you will really get, especially men. By the way, I mentioned this last time because, like for prostate, you can do a simple PSA test, right? PSA, prostate specific antigen. It's a tumor marker. He's laughing.
So that means you take a drop of my blood?
Yes, we take a blood sample and then we measure the levels. I said it before, the normal level is 0 to 4. So any high level is a suspicion and will warrant further investigation.
Okay.
Yeah.
Doc, let me ask you this, because I feel like the way we are forced to file taxes whether we like it or not, and it's a good thing, right?
Yeah.
So whereby you know by 30th of June you need to have filed your taxes. Is it possible that we introduce these kinds of laws in this country whereby after every 2 to 3 years, I don't know the amount of time we need to consider this, but like you need to go for screening?
Nothing is impossible.
We put
needs
it in
policies.
Yeah, we put it in law.
Yeah.
Na hii si tafadhali. It's not at your request that we're asking, you need to go. No, we make it law that by this time, every 30th of June, like we do KRA returns, after every 2 years, you need to go for screening. For men, tuende hiyo tukafanyia PSA and other kinds of screenings.
Yeah, I think it is possible. Nothing is impossible. We just identify the high risk population and the most common malignancies, because you can't screen for everything, and there are some tumors of which even with screening there's a lead time bias. You understand? So it's very possible, but
Policies.
Policies and a lot has to be kept in.
Even with policies.
Yeah.
Let me repeat, if you're talking about healthcare seeking behavior, it goes beyond just wanting to be healthy.
So I think what he's saying is for it to be compulsory, and it's not financially, you
Even
don't
if
need to pay.
Even if it is, he gave the example of KRA. Right.
Yeah.
How many people do you know of in that WhatsApp group that you belong to, who actually file their taxes on time?
My friends are all law-abiding citizens, so every one of them does their file return.
See, the girl is laughing because she knows it's a lie.
No, because I do file my taxes in return. KRA, please don't come for me.
No, it is his friend that I'm referring to.
Maybe everyone I know is a law-abiding citizen. But, and also, for example, if I go to hospital today, to have checked, to be checked for whatever thing, whether I've gone there and I'm telling my doctor I have a migraine, is it possible to just have that included as we check movies migraine? Can we also confirm that his prostate is okay? I think
there are some facilities, they have packages, like screening packages, of which you can have several tests done according to which one you choose. But it's very possible for us to also have that in our government facilities.
Yeah.
And
I think that, because if we look at the cost of treating versus the cost of preventing, we tunaweza saidia sana. And sometimes, even if there's a cost implication, imagine if 50 million of us each contributed even just 100 bob towards that. I think it would go a long way.
What? How much?
100 bob, 100.
Huh.
And City, before you say anything, let me move on to something different.
Okay, I wanted to, let me just not comment on
No,
that.
okay, no, comment, please.
No. I don't know. I was just thinking about SHA, but let me just leave it there.
No, you can comment, Daktari. I mean, this is a free space. We have lawyers. They can protect you in case you get yourself in trouble.
It's not about lawyers. I think we are contributing more, but is Shah offering more? That was just my thought. Yeah.
It's a good thought. It's a good thought. You know, the thing we don't do whenever we discuss issues, especially with government provided services or government intended services, we never look at it holistically. See, universal healthcare is really difficult to actually implement. Even developed nations whom we admit have the wealth have difficulties implementing it. This America people keep talking about, my friend, they have problems implementing that same process. Okay? Part of the reason has very little to do with just the money being available. Not that. If we are looking at specific issues that we have in our country, and we look at the thing that kills us the most, or the things that are likely to kill us the most, or the things that are likely to bother us, the discussion around prevention falters and collapses because we haven't bothered to even understand how it is we relate to health care. The common one is an absence of the financial might and the poverty levels, as is often quoted. What we understand illness to mean, what we understand diseases to mean. The reason why you have an adherence problem with something like antibiotics is because of that factor. If we feel better, as far as we are concerned, we are well.
Yeah. You take antibiotic for one day and that's it.
You're better, so you're okay. Now, all these things, when they are understood, then even this story of the preventative aspect of healthcare, it'll be infinitely easier because it's something that people will have comprehended and internalized. But so long as we're juggling all these things that seem to be competing for our attention, healthcare, unfortunately, is not number 1, 2, or 3.
Yeah,
it is not.
Sure.
So, as he was saying that, in my head, I was just trying to understand our habits also from a very young age, because we also see how our parents do things. They have a medicine cabinet where they have antihistamines, painkillers, and
PPIs
some
for ulcers.
Exactly.
Yeah.
So every time someone sneezes, hey, unapatiwa hapo antihistamines. Pap.
Yep.
So even me, I grew up knowing the moment I feel like I'm getting a cold, I take antihistamines.
Yeah.
And that culture, unfortunately, has been inculcated in us. And now by the time, and even kwanza for men, it's even worse. By the time mimi unipata hospitali, mimi, welelelelele, nitakuwa hali mahututi.
True.
Yeah. So is it something that we can also start maybe teaching our young population, and by that I mean our children, so that by the time they get to our age, we actually take health more seriously, we go for screenings more oftenly.
Yeah, I think just like the way we're implementing HPV vaccinations and even in schools, I think even before going, these kids should have sessions of them understanding what that does, why they are getting it, and why it's important. Yeah, it's very important
to understand this thing better. Look at the healthcare seeking behavior of Africans who are medical doctors. It will tell you, Dr. knows what I'm talking about. It will tell you that this thing is part and parcel of us. Now, unless we can overcome it, because if those we go to help us with the healthcare issues, if they internalize it, believe me, they'll make it an issue whenever we go to see them. They never do, not really.
We do.
No, you make an issue of what has brought me to see you.
No, with the screening, I think the more we have these programs, we begin the screening ourselves. That's the only way we can attract more people to come in.
I worked in the field of HIV and AIDS for the longest time. And in theory, we said that those of us who are in that should get tested first. Then we had voluntary male circumcision, which was a preventative aspect of health of HIV. And it was also recommended that so that you can understand what the patients or the clients who come to you face, because we were working in Luo Nyanza, which was a predominantly non-circumcising group.
Yeah.
So people were encouraged to circumcise. Again, So,
No, but also I think, let me just mention this. One of the reasons why we are able to we are able to see many cases is the diagnostic modalities have really improved. You understand? And I think with that also we are able to detect cancers at an earlier stage and able to treat better. So it's not only testing, the testing mechanisms and all that, we've really improved and come a long way.
Yeah. We have a question here.
Yes.
From this is Anne. Anne is asking, maybe if you can talk about the machine again, the one that you spoke about earlier on, and I think you mentioned, is it like the first one in Kenya, Africa, or something?
So the modality of treatment by SBRT is Sub-Saharan Africa. So we spoke about when we began that the first radiotherapy machine we had was cobalt. It was a cobalt machine. It was
cobalt, the mineral.
Yes.
Okay.
It's a radioactive radioactive isotope that decays, and once it decays, it produces gamma rays. Now, those gamma rays are what is used to treat. Previously, we did not have 3D modality of treatment. It was just you were treating by bony anatomy. Like, you want to treat the prostate, you identify this is the pelvis bone and this, so I will treat in this area. So you will be treating a very large area, meaning that the side effect is extremely high. Understood? But now we've moved away from that. We have linear accelerators. With linear accelerators, we use electricity to accelerate electrons, which produce a type of radiation which is able to penetrate deeper with more accuracy, because we have different mechanisms of doing the conformality. There are different ways of delivering radiotherapy. 3D is three-dimension radiotherapy. Then we have IMRT, intensity modulated. We have VMAT, volumetric modulated. And we have the stereotactic. The latter is to the most precise. So our machine, we have the Varian Electa Versa HD. We are able to do stereotactic radiation. And with this, we have treated several patients, not only like localized disease. The beauty is, as I said, and I'm repeating, even in metastatic, oligometastatic disease, you are able to target the radiation to an area where this disease did not start in that area, but it has progressed to that area. So we have seen patients, I think yesterday we were discussing with a colleague, there is a patient with a breast cancer and bone metastasis, received radiation stereotactic 2 years ago. The patient is doing very well. I think yesterday the patient had a repeat MR and the brain disease is well controlled.
Also, this was a brain issue.
Breast that has spread to the brain. Now you localize those rays with high precision to the brain area to be able to take care of the metastatic burden in the brain. Yes.
All right. Let's talk pricing here, and I'll start by saying that there's this conspiracy theory, and there's so much evidence supporting it, that cancer treatment is usually very expensive because of big pharma. Yeah.
Okay.
Or is it big medicine, where like it's becoming expensive because even the control of medicine, control of equipment that is used to treat cancer is being done by a very small, let me call it cartel. It's like an international cartel that decides this cancer medicine is going to be sold at $1,000 per pill. Is that something we're seeing, or is it a genuine situation whereby medical research into cancer and the production of medicine and equipment is actually very expensive?
Okay, so I think also there's progress in that. What I mean is, when I first joined oncology, there were some medications that were very expensive, and with time the prices have really come down. With cancer treatment currently, as I said, it's not one treatment fits all. It's not like all patients have to receive chemotherapy, because when you tell a patient you have to get chemo, there's also that concept of, now this is the end of me. I'm going to have all these types of side effects and they'll be intolerable and I'll not be able to survive.
And even the quality of life
will go down. But we have moved to targeted treatment. So for this targeted treatment, and mentioning this again, like, let me give a very good example. For breast cancer, you can't treat without knowing the biology of the tumor. The biology of the tumor means you have to do the hormonal markers, and there is a marker known as HER2. There are 3 markers you have to do on that breast tissue. Only once you have those results, you will be able to know which treatment this patient is going to benefit from. Like if your HER2 is positive, HER2 is like a marker on the cell membrane of which it acts as a car accelerator. If it is positive, that cell will continuously grow. Even if you give chemo, when you don't give the targeted to keep that accelerator off, it will still continue to grow. So if for a patient, if for example a patient has this positive, you have to give targeted treatment for this. You have to, for you to achieve an excellent response. And this patient has to get this even before going for surgery. You get this treatment, specialized treatment, according to your tumor biology. The best outcome is if you have a pathological complete response. The meaning of pathological complete response is we've identified you have a 5-centimeter lesion. We are giving you treatment so that we can liquidify all this disease and the disease disappears before you go for surgery. And then once you go for surgery, the surgery is done at, not all patients get mastectomies. According to the indication, we can do a breast conserving surgery. The surgery is done where lumpectomy is done to where the tumor was. And microscopically, once the pathologist has a look at it, there is no disease found. These patients have an excellent survival and disease-free survival benefit because you gave treatment before surgery. Understood? And you gave the correct treatment. Yes, so there are some drugs, the targeted therapy, that are a bit expensive, but as new modalities are coming in, the prices will be a bit on the higher side. Immunotherapy, currently we are treating a lot of cases with immunotherapy, but as time goes by, I believe that the prices will go down. And let me just mention, NHIF was doing an excellent job because patients used to get at least 600,000 per year, and the spouse was also getting
the same amount.
So in total, this patient is getting around 1.2. What I saw was most of these patients were able to get at least some benefit, huge benefit. Yes.
Okay.
One of the things you must bear in mind when you talk about drugs
Yes.
is the research. When you have clinical trials involved with drugs, before you get to clinical trials, there is process of identifying the biology, and then discovering what components there are that will make up of this drug. Then there's the phase 1, the safety trial, there's the phase 2, the efficacy, and then you have the big phase 3 trial. These things cost. So by the time you figured out that this thing actually works, and that's what Dr. was speaking to, they are done in places that are not in our continent. So it works where it was done.
Yes.
But for it to work the way it should for us, they need to have been done here. So all those details relate to us directly. All these things have a cost. So originally when that drug is first out, part of it is to actually recover what it is that they spent. And when you give it time, because other drugs will now come in, because they figured out the magic of doing this, it gets cheaper with time.
Yes.
Doctor, I remember I did biotechnology at Kenyatta University, and there's one thing I remember. I don't know if I dreamed this or I actually learned this. Cancer cells are immortal, right? Yeah, so they
Is it a statement or a question?
It is a question.
Okay, are cancer cells immortal?
That's why I said cancer cells are immortal, right?
Okay, so when you learn through, when you just going to oncology school, I think you'll be taught about the hallmark of cancer cells. And these are several principles which enable these cells to grow and survive. So they're able to grow on their own. They don't depend on the blood supply of the body.
Because they create their own.
They create their own. They're able to evade the immune system. Meaning like they mask themselves. This is the concept of how immunotherapy works. They mask themselves such that the immune cells are not able to recognize the cells that are subnormal.
Okay.
You understand? And then they're able to evade and metastasize to other regions.
Okay. Thank you so much, Daktari. We've come to the end of the show. I hope we've done justice to this conversation. Lakini kama kawaida, we shall definitely invite you back again because I still have a lot of questions and to specific cancers as well. So we shall invite you, no usikatae kukuja.
No worries.
All right, sasa.